always stand up for our fathers. We want you to know we're with you. We're standing behind you 110%.
Hello, beautiful people, and welcome to A Father's Note, where we promote fathers through building men. I am your host, Lionel Nelson, and as always, we're certainly glad that you took the time out to stop by and to see about us, to check us out. We're certainly glad that you're a part of this broadcast tonight. The subject matter is a very important one. And of course, we're going to be discussing about raising awareness for prostate cancer. And, as I give thought to this, one of the things that I've come to realize is that, and I think it's no secret, and I think everybody who is a man, and whether or not you're a man or even a woman, you know that we as men do not take care of ourselves like we should. We're more quick to invest more in our automobiles, electronics, food, clothing, things of that nature. But the most important thing that we should place value in is our health, our body. And what good is those things, those materialistic things, if you cannot enjoy them, if you're not in a good physical shape or well-being, whereas that you can enjoy those great assets of life, whatever it is. So tonight we want to talk about prostate cancer, as I stated, and I think it's something that's very important. And the reason behind it is that because we want to inform you, we want you to be informed as a man of the different things in which that can affect your body. Okay, that can basically take your life. And if you don't have the information that you should have, guess what? Then there's a possibility that something, whatever sickness that goes on that's going in your body, can take advantage of you. And I know we did one session on where we talked about hypertension, about high blood pressure. And we know that high blood pressure or hypertension is a silent killer. And especially amongst black men. And we gave you all the statistics on that. So you have to go back and watch that particular video. But nevertheless, though, tonight we have a guest. We have a doctor that is going to be talking to us tonight. Her name is Dr. Tamika Joseph. And just to give you a little background on her, she studied her education. She studied at the University of Miami School of Medicine. She also has a BS, bachelor's degree in anthropology and human biology. My apologies for the tongue twisted there. Her experience is that she has served as a cancer information specialist with the National Center Institute. She has also studied internal medicine. She was an internal medicine resident. She was an ambulatory chief resident. I need to slow down here, as well as an associate primary care physician. Right now, she currently serves in the position of a medical director for Chin Senior Medical Center. And without any further ado, we're going to bring on our guest tonight, Dr. Tamika Joseph. Let's just say hello. Come on, let's give her a hand, please. Welcome her to the show.
Thank you.
Hallelujah. Great God. Thank God that you came on. And I'm sure you have some great information for us tonight.
Amen. Thank you so much. I'm very excited to be here this evening to do what I love, and that's really to talk about healthcare, to educate the community, and to really just serve, hopefully, as a vessel of information to guide people in the right direction. So thank you again. I really appreciate you extending the invitation to have me come and speak. You hit everything right on the nail as it relates to men's health, particularly Black men's health. For a number of reasons, our people aren't necessarily aren't able to prioritize our health because we have so many different stressors. But the reality is health is wealth, right? Because the quality of life you live is largely dependent on how you're feeling. So I am going to talk to you a little bit about prostate cancer. So I'm going to get ready to share my screen right now.
Okay.
I put together a presentation. Share screen.
So nevertheless, while you're doing there, may I ask a question? Why did you get into medicine?
So, so I have always had a passion for taking care of people, helping people, and I always had a general interest in science. And so, I mean, medicine was just something that I was drawn to ever since I was a little child. I think, and then as I grew older, I really stuck to that passion and obviously pursued medical school. Trained down here at Jackson Memorial Hospital and really, felt that it was a need not only just to help people, but I think it's important because there is a dearth of or a lack of physicians of color, Black physicians. We up until now, we still account for less than 5% of the population as far as like Black physicians are concerned. And we do know.
I don't mean to interrupt you, but now when you give that stat, are you referring to here in the county and
I mean in the nation, in the US of A? I think we're about at 3%. We haven't really budged much since the 60s, quite honestly. And we do know, I mean, there's lots of studies and evidence to show that, patients, Black people in general, tend to have better outcomes when they're being treated by physicians that look like them. And really, because it's about that cultural understanding. Health disparities do exist for a reason. And even in instances when they are able to control for socioeconomic status, and by that I mean, when they take you take a Black person who has the education and has the financial means, they're still not being treated, they're still not getting the same positive health outcomes as their white counterpart. So it's not just a situation of just education or finances. There is still a disconnect, unfortunately, between how our people are being treated compared to our white counterparts. And I think a big part of that disconnect is that there is a disproportionate amount of or there's not enough, I should say, physicians of color, Black physicians, Latinos. We need more physicians that reflect the communities that we serve. And so that is something that I'm very passionate about. And it's one of the reasons why when I was done with my training, I wanted to make sure that whatever I did, I was able to, hopefully have a good impact in our communities, because we need more people of color in our communities taking care of our mothers, our fathers, our sisters, our brothers, our children.
I to tell you the truth, I wouldn't even have known that, because to be honest, my primary physician, I've been going to him for over 20 years now, and he just happens to be, Black or let's say of Jamaican descent.
Mm-hmm.
So I found that very strange that that's a very low number. And so maybe we need to, those of you who are watching, listen, encourage your child, especially if they like biology and science or whatever, encourage them to get into the medical field, because it's obvious, based on what Dr. Joseph have just shared with us, we need more of us in that field to help us, to better relate to us. But I think that's some great information. So tonight, you're gonna be talking to us about prostate cancer. Why prostate cancer?
Why that? Because this is it's a cancer that largely, exclusively affects males, right? Because only men have prostates. It's also a cancer that we see disproportionately affects Black men. And there are ways, fortunately, to really get ahead of it. And I think it's important because, sometimes people hear the word cancer and they just, shut down because they get scared. We obviously almost always associate cancer with death. And I think it's important to know, what you may potentially be at risk for, so that you can be aware to look out for the signs and symptoms and really know what's out there to help you. so that, if something is going wrong, you feel empowered to go to your doctor or go to a doctor and, express your concerns, and that may have questions, you'll know what questions to ask. So I think that's what makes this topic a very good topic.
Yeah. So you have a presentation that you would like to share with us. How about go ahead and start your presentation. Give us all the information that you can give us.
Okay, perfect. Okay, everyone, you can see my screen, correct?
I see you, but not your screen. Okay, wait a minute. Hold on, it's on my end. My apologies. It's on my end. Okay, there we go.
Perfect.
All right.
Okay, so prostate cancer. So I wanted to first start off. I apologize if some of you find this to be graphic, but I think it's important to really understand what the prostate is, where it's located, so we can really understand what the cancer is and why you may have the symptoms that you have. Okay. So what is this?
Before you start, hold on a minute, because it's saying that we have an issue with our audio.
Okay.
So the question is it I that sounds like I'm underwater, or Miss Joseph? Both of us sound like we're underwater. Well, there's nothing I can do right there for that right now. But nevertheless, we're gonna go forward with it anyway. So I do apologize for that.
Okay.
Joseph,
do you want to maybe try muting yourself, and when I talk, and maybe that'll help clear it up? Maybe that'll stop some of the feedback.
That really won't be on my end.
Oh, okay. So it's probably me then.
Yeah. Let me try it anyway. Okay. So go. I'm muting myself now. Go ahead.
Okay. I apologize, everyone. Hopefully you can hear me clearly. So what is the prostate? So the prostate is a gland that makes fluid that is part of semen. Okay. So what you see here is what we call a sagittal view. So imagine yourself standing sideways and they're taking a picture of it. So this right here is the bladder. Okay. This is the rectum. This is where your prostate sits. Okay. It sits below the bladder, in front of the rectum, and it basically surrounds what's called the urethra. And so the urethra is the small tube from which urine exits the bladder and exit out of the penis when you urinate. Okay, so this is the prostate that we're talking about, and we're going to talk about what happens when cancer grows in this tiny gland. Okay. So prostate cancer, basically it happens when here you have your normal prostate, right? Cells within the prostate in the gland, basically something happens and triggers it to switch from normal healthy prostate cells that produce fluid to abnormal cells. Okay. When this happens, it leads to abnormal growth, right? Because when you have abnormal cells, they essentially divide, they continue to replicate, and when that replication happens unchecked, you have a growth, and this growth is the cancerous tumor. So this is an example of the prostate with an actual cancerous tumor. And if you can see this, with this actual cancerous tumor, the prostate actually gets bigger, right? And so when you think about it, because this gland surrounds what's called the urethra, which is again the tube that, where urine exits from the bladder to go outside, it basically squeezes on the urethra and it can cause symptoms. Okay. So now, what are the risk factors for prostate cancer? Like most cancers, this is a disease that you tend to see in older men. Generally speaking, 50 and over. So by virtue of getting older, it puts a man at risk for potentially developing prostate cancer. Race, unfortunately, is also listed as a risk factor. What we know from decades and decades of research is that there is a higher incidence in Black men. Now, the reasons behind that really vary. It's not as definitive as saying, there's something genetically, specific to Black men that makes it, that makes this particular group of people more vulnerable. This is just what we see. We don't have enough data to definitively state why it is that, but similar to a lot of diseases, unfortunately, this virtue of being Black does put us Black men, at a higher risk. Another risk factor is family history. So when we talk about family history, what we mean specifically is first degree relative. So if you have a history of someone in your family, specifically if you're a man and your father had prostate cancer, particularly if he was diagnosed under the age of 65, that puts you at risk. Now, it's very important to understand that having an increased risk doesn't mean that, hey, because your dad has it, you will get it. It just means that you are at a higher risk of getting prostate cancer compared to another man your age who does not have a family history of it.
Now let me ask a question here, because something you said there that caught my attention. You said that if your father was diagnosed with prostate cancer prior to 65, that up your chances of getting it yourself or having it yourself. Am I understanding that correctly?
Yes.
But now if you get it later in life, it decreases your chance of having it.
That's a very, very good question. And actually, yes. And so the reasoning behind that is it's more likely. So typically when we see prostate cancer diagnosed in younger men, you're more likely to see some type of genetic abnormality. And by that, I mean, there may be some type of gene that triggers the prostate cells to grow abnormally. So you're more likely to say, this could be a potentially inherited trait, versus if your dad gets it later on in life, then that just means that was his own individual risk.
Okay, so now let me ask you one more question going back to that. Now, let's say my grandfather was diagnosed with it, but my father wasn't. Does that still give the possibilities of me, it happening to me ending up with prostate cancer myself?
Another excellent question. So we would call that, you would have average risk, meaning that, because when we talk about first degree relative, we've only really seen a correlation directly with that parent, with your actual parent. Once you start getting into grandparents and uncles, the risk isn't as high. Now, it doesn't mean that you won't get it, because again, risk factors doesn't mean that you definitely will or you definitely won't. Risk factors just means that, hey, this individual has a higher risk compared to the general population.
Gotcha. So now going back to the gene, you mentioned about the gene. So let's say let me ask the question this way. So let's say if my grandfather, I know you said first degree relatives, I understand that. But if my grandfather, let me, we can have this dialogue real quick, up and close and personal. If my grandfather has the gene, does that mean that my father has the gene and the possibility that I would have the gene as well?
So that's another good question. So what it basically, because remember that with genetics and inheriting things, right? Every time, and the sperm meets an egg and a life is created, it's almost kind of like rolling dice in terms of what genes you get. So not all genes are passed down directly. So you're 50% your mother, 50% your father. Once you start talking about grandparents, you get 25% of the genes from your grandparents, right? Gotcha. So we don't know for sure. So it's not going to be a direct correlation, because whatever combination of genes you got from your grandfather could or could not, may or may not include that particular gene. And even then, it's not as clear as like, okay, this is a dominant gene. That means if you get it, you're going to automatically get whatever disease comes from that. So when we talk about genes, it's very variable in terms of how that gene is expressed in your body.
Gotcha.
In this particular case.
But you still should be aware of it. If you
100%. 100%, because that's something that we don't do that good in our community about, is talking about diseases in the family. For whatever reason, sometimes it just comes from, people just not knowing what they have until they pass. And then other times it just comes from us not understanding the importance of having real conversations about, like, hey, grandma had breast cancer, grandpa had prostate cancer. It's important to have these conversations so that family members are aware and children are aware, because this all plays a role in how you move and what you do to protect your health.
Okay. I have tons of questions in my head.
Oh,
here.
no, I appreciate it. I definitely want this to be interactive. And so even to the audience out there, please, I have no problem stopping in between. This isn't a lecture. It's supposed to be a conversation. I just wanted to have some context so that you can formulate questions. But sometimes we don't know what to ask until the information is presented.
Now, I know you're doing a presentation, and I don't want to get ahead of you. But at what age? Now, let me go back to your screen here, because you mentioned that once. So let's say once a young man turns 50 years old. I'm gonna call him young because these days 50 is young.
Oh, most definitely.
That's me. He should begin when he is attending the doctor. That is something that his doctor should be looking for, checking out, as his prostate. Correct.
So that's a very good question. I actually didn't include a slide on this, but I'm more than happy to talk about this, because what you're talking about is what we call screening, right? We know screening basically, or doing screening tests, essentially what that is doing a test to potentially detect for disease before it actually manifests itself, right?
Okay.
The unfortunate thing is, while we do have some great screening tests for, say, breast cancer or colon cancer, unfortunately for prostate cancer, we don't have the best test for screening for prostate cancer. We have good tests for detecting. So the difference is diagnostic tests are basically tests that we do when there is a symptom.
Right.
Okay. So I'm going to get into the testing. So it doesn't mean that we can't find it. We definitely can. But when you talk about, like, hey, when I go to my doctor, can they just test me to see if I have prostate cancer? I'm going to go into it, I think, in the next slide, or in 2 slides from now. So to kind of break that down, and then I'll explain why I didn't include the screening slide, just because of what I mentioned. We don't have great tests. There are tests available, but like everything, it comes with the risks and benefits.
Okay, so let me just interject this real quick. So to the viewing audience, if you have any questions for Dr. Joseph, please put them in the chat, and we'll definitely see about responding to getting an answer for your question. Okay, so proceed, Dr. Joseph. Thank you.
Okay, no problem. You're welcome. So what are the symptoms of prostate cancer? So oftentimes you have no symptoms at first, right? Simply because, like, similar to the picture that I showed, it has to get to the point where it's causing the prostate to enlarge for you to, actually impair the way in which you urinate. That can lead you to even detect that something's amiss, right? And so some of the common symptoms that you see is trouble urinating. So what we talk about that is, like, sometimes, patients will tell me that they'll go to urine and they have the sensation to urine, but there's like a slow stream or dribble, or they can't urinate. In some instances, they actually go, but they only urinate a little bit. And so they always consistently have to go to the bathroom. Now, I put this in bold that you can see these symptoms in other conditions involving the prostate. But because I wanted to focus on prostate cancer right now, I didn't go into detail. But just keep in mind that, having difficulty urinating does not mean that, oh my gosh, this could be prostate cancer. It's just one of the symptoms that we can tend to see with that.
But you should still go, if you're having that issue, you should go get checked out. You should go get checked out.
Absolutely. And so in this picture, I talk about things: interruptions in the urinary stream, frequent urination, especially at night. Oftentimes, my patients will complain about, like, I wake up 4 or 5 times in the middle of the night to go use the bathroom. Hesitation.
Let me ask the question to that. So is that like every night, or just occasion when you talk about 4 or 5, waking up 4 or 5 times in the night?
So it depends on, what's going on. So some of my patients may be complaining about every night, and it really affects their quality of sleep.
Gotcha.
And it doesn't, remember, some of these things don't happen like immediately. It's like a slow progression, right? Because most of us, especially as busy adults, we may feel something and it's like, oh, okay, we ignore it until it becomes a big problem.
Right.
Yeah, and so that's typically what happens. Some other things, they feel a feeling that the bladder is still full after urinating, so you don't feel like you quite emptied it. Or sometimes you may have an urgent need to urinate, still having dribbling afterwards. So these are just some of the symptoms that you can see.
Mm-hmm. Okay.
All right. So now we go into how to detect prostate cancer. So going back to your original question as regards to screening, because again, there's no perfect screening test. Well, there's no perfect anything, but there's no gold standard screening test at this time, just because in the test that I'm going to go over, there's a lot of variability. Okay, meaning that there's not one particular test that we can do on all men, regardless of you having symptoms, that can detect prostate cancer without that is seamless. And I'll get a little bit more into that. So one of the first things that individuals can do, and a lot of doctors do, urologists in particular, and some, primary care physicians still do, it's something called a digital rectal exam. Now, albeit it's not the most comfortable exam, and there's a lot of variability because it's really about what you're feeling, right? And so in this exam, the doctor, as you can see here, places the finger into the anus to go up the rectum. And so if you remember, again, in the first slide that I showed you, the prostate gland sits here. And so when you stick the finger up into the rectum, you're able to feel along one border of the prostate. And if you're experienced enough, what you're feeling for is any lumps or bumps, right? Because if you have prostate cancer, the abnormal cells will continue to grow and they will form a lump, and you're feeling that. So now, obviously, this isn't a gold standard test because, what you feel is you're really relying upon that the tumor has grown big enough for you to feel, right? Or B, you're really relying upon the experience of the person doing the exam. And, some of the challenges to this exam, obviously, is that it's not comfortable. Most people are very squeamish at the idea of someone sticking their finger up the anus into the rectum. And so it's not the ideal screening test if you're not having symptoms. Because in the similar vein, you could have symptoms, but the tumor isn't large enough to be felt by the finger.
Right.
And so again, I'm not saying that this test is not useful, but I will say that we do have better tests, so it's not as commonly practiced as it was, say, 25 years ago.
So let me ask you a question here, because I don't want to get ahead of your presentation. Mm-hmm. But going back to the tumor itself, is it the cells that causes the tumor?
Yes, that's a very good. I'm loving these questions. So cells, essentially, every organ that we have in our body is a result of cells that came together to form tissue that formed an organ, that formed a gland, right? Normal, healthy cells. So whenever we talk about cancer tumors, especially when we talk about cancer tumors, basically it's a growth of abnormal cells.
Okay.
And because a normal cell, it grows, it divides, it has a pace at which it grows and it dies. Cancer cells, they grow unchecked and they don't die.
Gotcha.
And so that's what leads to a tumor. And that's what leads to, once you have a tumor in any organ or gland in the body, it affects the way in which that organ or gland functions. And it can affect the surrounding structures in the body, based off of because that tumor is now taking up space where it was never designed to be.
Gotcha. Okay. All right.
Okay.
Mm-hmm.
All right. So one of the good tests that we do have is a blood test, something called the PSA. A lot of you may be familiar with it if you're an older individual, or if you've ever taken your dad or elder male family member to the doctor. So the PSA stands for prostate specific antigen. Basically, what it is normally among the different things that the prostate does, it produces this protein, right? And so we're able to check the blood to see if it's elevated, right? Because typically, if you have prostate cancer, this PSA is elevated. So
Okay.
the downside of this test, and what I was going to your original question about screening, is it's elevated in prostate cancer, but it's also elevated in other conditions or diseases of the prostate. So like if you have an infection in the prostate, inflammation in the prostate, or even just an enlarged prostate, which you can see in older men, just naturally, it's one of the changes that happens in the body for men. So seeing an elevated PSA isn't enough to say, hey, this is prostate cancer. Because you can see an elevated PSA in prostate cancer, but you can also see an elevated PSA in an infection. You can see an elevated PSA in the things that I mentioned. So this is another reason why, the U.S. Preventative Task Force and other medical societies don't recommend routine testing of PSA for all men. They do recommend it if you have a family history, like we mentioned, or if you're having symptoms, because that's the first step or first test that can be done to help detect prostate cancer.
Okay, so let me ask you a question here.
Mm-hmm.
So listen, I'm going to use myself. Every 3 months, I think quarterly, I go get a blood test. I go to the doctor. I'm 61. Mm-hmm. Okay. And to some people that may seem to be a bit extreme, but I care about my health because and it's no secret to many of my viewers. They have heard me say it, even family members. I plan to live to see 110 if I can.
Hallelujah.
That's my goal, but in order to do that, I need to do those things that are necessary to preserve my body. Now, the question I want to ask, so when, let's say, I go to the doctor, I go do my labs, and so then when I go to the doctor, is that something, if I understand what you said correctly, that they automatically check for because of my age, or is it something that would show up anyway?
Got it. That's a good question. So it depends. So really every physician has autonomy. So we have these things called guidelines, like different specialties and medical societies create like guidelines kind of like as a benchmark for physicians to use as they're, practicing medicine. And these guidelines basically come from, years and years of research to kind of weigh the pros and cons of doing certain tests and studies. And so the PSA has had a lot of controversy, I would say, for the very reason that I said it's not as specific enough to prostate cancer for any society to say, hey, we should be testing this in all men. So I would say about 10 years ago, if not 2011, maybe 2014, forgive me because I don't know exactly, but new guidelines came out that recommended, that basically no longer recommended doing PSA in all men over a certain age. What they did say is particular groups, you can consider it, and anyone else you should have the discussion with. So when we talk about particular groups, we mean groups that may be at risk. So African-American men, those men that have a family history of prostate cancer, those are pretty much the two groups, right? So that being said, it doesn't mean that you, Mr. Nelson, shouldn't get tested for a PSA. It just means that you need to talk with your doctor, or your doctor would have a conversation with you to let you know that, hey, the PSA is a test that can, yes, help us see that there's something going on with the prostate. It could be prostate cancer, or it could be something else if it's elevated. Because the next step, if you have an elevated PSA, the next step to really definitively find out whether or not this is due to cancer or something else is a biopsy. And because a biopsy is an invasive procedure, that is one of the reasons why we don't recommend PSA on everyone because we know that there's going to be a proportion of people that are going to have an elevated PSA just because they have a large prostate. But we don't want to put every man that has a high PSA through a biopsy unless there's a high suspicion that it's cancer.
Okay.
And what helps us know that it's a high suspicion is if you have symptoms, if you say, hey, my dad had prostate cancer and he got it at 45. Right. I want to check my PSA. Okay. So it's a very long, drawn out answer, but, unfortunately for this particular cancer, it's not as like cut and dry. The PSA is not like a mammogram. We know very clearly that mammograms help us detect breast cancer in women. And so we recommend that all women starting at age 40 or 50, depending on which guidelines you're looking, should get a mammogram every 2 years or every year.
But it seems based on the information that you're sharing with us right now, that unless you have knowledge of it or the information that you're sharing, it could possibly be something that if you're not careful, you can overlook. 100%. So having this knowledge means that, okay, well, I'm of this age. Yes. I'm Black American or American who happens to be Black, as I like to phrase it. And I have history of it. You know what? Hey, doc, can you check for this, please? That's pretty much where we are at right now. Because again, based on what you're saying, there is really no cut and dry examination for it. So the information that you have is what can save you down the line.
Yes, 100%, 100%. I think what's important, the most important thing is knowledge is power, right? So once you know what's available, you can have that discussion with your doctor and you can weigh the pros and cons and see what's best for you. But I think the first step is knowing what it is and what's available and what are things that you should be asking for and what you should be talking about. So and 100%.
Let me interject this here to all my brothers. Listen, even with what you just heard about the examination, the process of the examination, please do not allow that to cause you to fear going to get checked out. You need it. This is a necessity. What do you like most of all? I'm sure you love life and health more so than sickness and death. It's no question about it. Let's just be real about it. So I think as much as you possibly can, do not avoid, if you are having any of these symptoms, please go get yourself checked out. Let's go ahead and continue, Dr. Joseph. Thank you so much.
You're very welcome. Okay, so now, how to detect prostate cancer biopsy. So this is the only definitive test that can confirm prostate cancer. So like I mentioned before, I showed you first the digital rectal exam. You can feel a lump, but feeling a lump, you can't say, hey, because this lump, it's cancer. It could just be, there's a lot of variability. God designed us all very uniquely. And so not every person is exactly the same. You can do a PSA because, hey, I'm having urine symptoms and I'm waking up in the middle of the night and your PSA can come back elevated. But even then, I get that result back. I can't say, oh, this is cancer because like I said, your PSA could be elevated because your prostate is just enlarged. It just naturally, because with time and age, it's gotten bigger. And as a result of that, you're producing more of that protein and that's spilling into the blood. The only way that we can say for sure that this is this is a prostate cancer is by a biopsy. And a biopsy basically is a procedure in where the doctor, at this point, it's usually a urologist, which is basically someone who specializes in the genital urinary tract of the man. He or she takes a tissue sample of the prostate. It's a procedure usually done at the office under sedation where they go in through the rectum. And sorry, this didn't come out as clear as I thought it would, but they use a needle to get a tissue sample of the prostate, okay?
Gotcha.
And basically when they get that tissue sample, that's tissue is then sent to a lab and is analyzed by another doctor, a pathologist, under a microscope to confirm whether, in fact, this is prostate cancer. And so this slide really kind of, I think, explains what I was trying to express when I said that there's not really good screening tests, right? There's a digital rectal exam and the screening, the blood test. And because that blood test can be elevated in a number of conditions, we don't want to subject every man that has a high PSA to this, unless, again, there's a very high suspicion. Symptoms, the PSA is very high, family history, and or you fall into one of those groups.
So in essence, what you're saying then is that even though the doctor may detect it, what he's going to do, he's going to monitor it, and with asking questions and examinations that are not invasive, before he decide that, you know what, this is a necessary procedure that we're going to need to do right now.
Very good question. So again, that depends, right? So it really depends on the value of the PSA. But most importantly, any elevated PSA at that point is because usually that first blood test is done by your primary care doctor, unless you're already seeing a urologist for some other type of urinary issue. Generally speaking, the PSA is done by, an internist, family medicine doctor, some type of primary care doctor. Once it comes back elevated, they're going to be referred to the urologist, and the urologist is going to evaluate you, look at the numbers, and really have a discussion. And ultimately, that decision is going to be made between you and the urologist. Right. Because you really want to assess the risk, right? Because you want to assess how high the suspicion is that this could be, prostate cancer, and then do the biopsy. And in some instances, I've seen, where, if the PSA isn't that high, the urologist is like, okay, we're going to monitor it. We want to repeat it again in 3 months. If we see it's climbing up, then definitely we're going to schedule you for a biopsy. If we see that it's going down, then we know that, hey, this is just a transient change in the prostate. But I think the key thing is first establishing that relationship, not only with your primary, but then with the specialist if that PSA comes back elevated.
Gotcha. Okay. All right. That's good information. Thank you.
You're very welcome. All right.
If please, audience, if you have any questions you'd like to ask, whether you're watching Facebook or YouTube, please let us know. Put the questions in the chat, and we'll definitely get it to Dr. Joseph for you to receive your answer. You may proceed, Dr. Joseph. Thank you.
Awesome. I love these questions. Thank you. Oh, goodness. I think my computer freeze. Okay, there it is. All right. So this slide. So once the biopsy is done or there's a very high suspicion that this is prostate cancer, or the biopsy has confirmed it, there's additional imaging studies that can be done to basically detect if the cancer has spread anywhere else. Okay. Because, once you start to have abnormal growth of cells and you have cancer tumors, the cancer is trying to survive and thrive, and so it can go to other parts of the body. So there are imaging tests that can be done typically after we've confirmed a diagnosis of prostate cancer to see if it's gone anywhere else. Most common place that first the prostate the cancer can move like around like your genital urinary tract, but at other far places that I can go to is like the bone, so these imaging studies can help us see how big the tumor is in the prostate, whether it's compressing anything, whether it could be compromising, the flow within the kidneys, or if it's spread to areas like the bone.
Mm-hmm.
Okay.
Right. That's one of the things I saw, because I found that very interesting, that prostate cancer often spreads to the bones. It also says about lymph nodes as well, right?
Yes. Yeah. Okay. So lymph nodes are usually like the highways that the cancer cells can use. Like lymph nodes and blood cells are the highways that cancer uses to get to other parts of the body.
Okay. All right. Good information.
All right. So some good news, actually, and I know that's sounds like counterintuitive to say good news when you're talking about cancer. So prostate cancer, although it is a cancer and can be deadly, it often isn't. It's actually one of the more slow growing cancers, believe it or not. So it doesn't mean in any way that, you should not be vigilant about potential symptoms or about your own risks. It just means that the options as it relates to treating it vary depending on your particular situation. Okay. So when we talk about how to treat prostate cancer, one of the treatments, believe it or not, is something called watchful waiting. So a lot of times, depending, once whether or not it was symptoms or maybe it was an individual that was just concerned for their own risk that had an elevated PSA, a biopsy was done and it was, the tissue sample came back positive for prostate cancer. Depending on the staging of that, cancer, and staging is something that we're able to do from this slide, from the imaging studies that are done.
Right.
Imaging studies are done, they see that hey, that cancer is confined to the prostate, it's a tiny little tumor. Some individuals, based off of what they know from their particular case, and after having discussions with their doctor and their family members, decide to do what's called watchful waiting. So watchful waiting is basically a term that we use when we say like we're treating symptoms as they arise. One of the reasons why this is a potential option is, again, because prostate cancer generally is a slow growing cancer. Oftentimes it's diagnosed in men later in life. A lot of times they have other medical conditions like, hypertension, diabetes, heart disease, other conditions that actually take more precedent in that, like, it's actually causing symptoms or what have you. And because this cancer is so slow growing, they choose that, hey, we don't want to proceed with any particular treatment at this time.
Okay.
And it's something that is afforded to them, again, because of their particular situation, their tissue type, the whether or not the fact that it's confined to one particular location, no evidence that it's anywhere else in the body, and them not actually having any real symptoms. So they decide, hey, I'm 85 years old, I just want to continue to wait. If I start having some symptoms, I'm going to come back.
Okay.
And so obviously they have this established relationship with their doctors. So it's not like they watchful wait on their own, like they go away. No, it's like, they're at least routinely seeing a doctor. Okay.
So in essence, your treatment is custom made.
Customized. Yeah.
Customized to your need, basically.
Yes. Yes.
Okay.
And, this isn't something that can be afforded for all types of cancers. Every cancer is unique. And it's just fortunate that, generally speaking, the majority of prostate cancer in general tends to be slow growing. And so it affords more time and to think and to actually provide these types of options.
Okay. All right.
Okay. One of the things that I remember learning when I was in training was that oftentimes older men in particular die. Like they have prostate cancer, but they pass away from, a heart attack or a stroke, like some other illness, because that prostate cancer really has not given them any problems. And they just, do their routine checkups and they're doing okay.
So it is curable, sounds like what you're saying. Or
in some instances, most definitely. So right here, this isn't really so much talking about a cure. It's more so talking about that in some instances, it can be so slow growing that it never has a chance to spread.
So in essence, under proper maintenance, and as long as it doesn't go undetected.
As long as it doesn't spread and doesn't start to cause problems, correct.
Okay. All right.
Okay.
Okay.
In some instances. Now remember, every case is unique. So it doesn't mean that once you get this tissue diagnosis, you can, disappear. It's more so, okay, tissue diagnosis. Let me sit down with my urologist and the cancer doctor and my primary care doctor at different things and really discuss my options based off of my case.
Mm-hmm.
Okay.
All right.
So another option is what's called active surveillance. So similar to the only difference between this and watchful waiting is that with active surveillance, you're doing more frequent checkups, right? So in this scenario, again, still slow growing, still early stage, confined to the prostate. So, an individual is discussing with the doctor and, you decide, okay, this is slow growing. It's not anywhere else. I don't want treatment right away. However, I'm going to be checking in with the doctor monthly or every 2 months to see whether the cancer is continuing to grow. And the way in which they can check that is by doing blood work.
Okay.
And based off of that, you see the PSA is continuing to go up. If you starting to develop, or if you're starting to develop symptoms, and or if repeat imaging shows that, hey, now this tumor mass seems a bit bigger, then you decide, okay, we're going to start active treatment. Okay. So, these two options, generally speaking, are, obviously it's an option, are options for people who have early stage, very small, like tumor, or what we call a low disease burden. And they may, depending on what's going on in their life in that moment, perhaps they have other pressing health issues, or perhaps they haven't really come to terms with, wanting to proceed with treatment. Those are viable options for them. But I think what's important, and I can't stress the most importance of, I can't stress this enough. It's really important to have that dialogue with your doctor, to have that type of relationship where you can do what's called shared decision making, where you can, go there with the questions, and really have a discussion about what the best options are for you and what your needs are, what your concerns are.
Okay. All right. Well, we have about another 8 minutes.
Okay. Not a problem. I'm almost done. Yeah.
Okay. All right. And also, I think you have a guest, someone backstage that's waiting.
Oh, yes. You can let her on. She's gonna listen, and then
Okay.
Yeah.
Let's see. Does she show up soon? All right. Well, she's not there yet, but she's up. Okay.
Okay. All right. So just quickly to go through it, some of the options. So how to treat prostate cancer once you've been diagnosed. Here you can see the prostate, right, with the cancer tumor. There's surgery where you can remove it. So here's the prostate where it normally would be. Here's the person afterwards with no prostate. Okay.
So this can be done through surgery. This can be removed through surgery.
It can, they would actually remove the entire prostate. But every treatment option comes with this risk and benefit. So there are a lot of different things that can be done. So yes, if it's just confined to the prostate and it's nowhere else, you can remove the prostate.
Gotcha.
And then the cancer is gone.
Well, that's good. That's good news.
Right. So another option is radiation, and this is basically a type of treatment used to kill the cancer cells. There's external, where I have a picture of it right here, where they use a machine to direct it towards the area of the body to basically kill the cancer cells. And there's internal, where they use a type of source where it's placed directly into the prostate. I don't have a picture of that, but the idea is the same thing, to kill the prostate cells. So you still have a prostate, but albeit it's a prostate that has undergone radiation. So that's another potential treatment option.
Is this treated with a medicine, a particular medicine?
Oh, you beat me to it. So another option is hormone therapy. So generally, when it comes to prostate cancer, it basically feeds off of male hormones, right, made by the body. Okay. So there is a medication, usually in the form of an injection, that's a hormone, basically blocks the production of that hormone, and that can help to shrink the cancerous tumor. Okay. In more extreme or advanced disease, I don't really see this being done that often. There's also surgery to remove the testicles, because that's where the hormones are actually produced. Again, not very commonly done. I just included it there for information. Right. The most common thing typically in terms of hormone therapy is a medication. It's usually like an injection once every 3 months.
Okay. All right.
Okay. And then lastly, there is chemotherapy. Again, this tends to be more reserved for advanced disease. So chemotherapy is basically a term that we use when we provide some type of medicine that's given to kill the cancer cells or to stop them from growing. Typically, again, advanced disease, or it's an option if the hormone therapy doesn't work and we continue to see progression of the disease.
Okay. All right. So in essence, though, number one, again, I think it's going back to what I was saying previously. It's just a matter of that you being more proactive about your personal health.
100%.
Than anything. That way you can always be ahead of if anything is occurring. So, I mean, just as, and I'm going to use a man's thing, just as you would definitely provide maintenance to your vehicle, your personal vehicle, you should be providing maintenance to your body. Okay, I'm going to bring your guest on. I kind of brought up a couple of times. The lighting, you're lost in the lighting. We do not have good lighting here, unfortunately, but she's here.
Awesome. Awesome.
Why don't you introduce yourself, please?
Hi, everyone. My name is Jennifer. I'm one of the growth consultants for Chin Senior Medical Center.
Mm-hmm.
I work out in the field. I make house calls to seniors, giving them a chance to understand what Chin provides and what we do for seniors in the community, as far as healthcare, insurance, or trying to get a great primary care doctor, giving them tours to the facility to meet the doctors themselves and ask questions.
Okay. All right. And I just put up the number if you want to reach out to them. So did I hear you say you make house calls?
Yes, I work in the field.
I didn't think doctors still make house calls.
Oh no, not
Oh.
no, not
I'm
me.
not a doctor.
Yeah, she actually is, a great addition to our organization.
Okay.
She helps, basically put the word out there and helps us to,
Okay.
bring, more members of the community to see our centers and join our centers. We really, our mission basically is to serve seniors. We really champion having real strong doctor-patient relationships, and we really just want to provide good medical care to the underserved communities. And Jennifer, goes out to the communities, does make house calls, does events in the communities to really help connect patients with, a medical home and a doctor.
I'm glad you said that, because I think that's the other thing too, is that I'm targeting men. Most men don't have primary physicians.
That's right.
You agree?
Oh, well,
Yeah, I ran into a couple of them. I know.
And what's your response? What's the reasons that they give you for not having a primary physician?
They feel like they're healthy. If it ain't broke, why fix it?
Wow. So I guess that's how they treat the car then, huh?
That's right.
Wow.
Yeah.
I hear it so many times. I mean, I had a guest on maybe a month ago, and he's a nurse. He was a nurse, and he shared with us about two of his college friends, how both of them in their mid-40s lost their life because of not having preventive maintenance on their body. And it was absolutely shocking. These are young men, but yes, still, just as you stated, a lot of them, we feel that hey, ain't nothing wrong, I'm good. Or even if something is wrong, we attempt to want to live through it. Oh, it's going to go away.
Mm-hmm.
I ain't got to worry about it. And I think that I know you all targeted. You say that your main focus is our senior citizens, which is good. I commend you for that. But what would you have to say to younger men as well?
Take your health seriously. What you do now really will affect you when you get into your 60s and 70s. So definitely don't delay getting a doctor. At least see a doctor once a year just to get some general labs. Take care of yourself, eat well, try to be active, limit your drinking. Don't smoke. If you are a smoker, really work to decrease the amount of cigarettes that you're smoking. We don't want to wait until we feel bad to seek help.
We have a question here. What age is for seniors?
That's a very good question. In regards to the people that we take care of Medicare eligible individuals. So generally 65 and older. However, there are some people who are on disability for a number of reasons that are Medicare eligible and can join our organization.
And
So for the purposes of our medical center, which we have several throughout Dade County, by the way. For the purposes of our medical center, seniors generally are 65 and or just Medicare eligible. We do take care of.
So it can start from 55 years old and up.
Yeah.
So if they don't have insurance, if they don't have the necessary insurance to come and be visited to visit Chin Medical, I guess you can provide assistance with them for that to see if they are eligible.
Yes, I do believe our membership growth consultants can really check to help to see what their benefits are, because there are a lot of individuals that they don't even know what they qualify for. And so we really want to help to bridge the gap to make sure that, you know, if individuals are eligible, that they can get the services and benefits that they need, and most importantly, the care.
Yeah, that's good information. So in essence, again, it's just about you being informative.
Yeah.
You're doing those necessary things. Just because, you know, well, I don't have the insurance, I can't afford it, I'm not going to worry about it. Let me just take these aspirins here or these Motrins, I'll be all right. You can't take that attitude. You should not have that attitude.
100%.
Yep.
No.
And I usually, when they say they don't have insurance, I will connect them with someone that can actually see what they qualify for through Social Security. Because sometimes if they're on disability and they don't know that they can actually get Medicare early, and they've been on disability for at least 2 years or longer, it's available for them to get it. They just have to call Social Security.
Okay, and you also provide transportation as well.
Yes, transportation.
Okay. All right. Anything else you want to add? Because our time has expired. But thank you so much, Dr. Joseph, for you coming on here and you taking the time out of your busy schedule to share this information with us. And I hope that it has been great and beneficial to our viewers and to our guests. And we certainly appreciate you. And also to you, Ms. Rowe, thank you for coming on and being a part of our broadcast.
Anytime.
Thank you.
Anytime. You guys reach out and we'll take care of you.
All right.
100%. We really appreciate you, and thank you for giving us the opportunity to meet and not only talk about prostate cancer, but also to share a little bit about our organization and what we do. Definitely, if anyone is interested, they have, you know, mother, father, aunt, uncle, anyone that is interested in touring the facility. Our number's on the screen. I can leave you with Jennifer's contact email as well, and we can set that up for you all.
Okay, so the question was there. I have another question that says, at which center do you work out of, Dr. Joseph? And I have a senior that's diabetic. Okay, you're out of the 95th Street, correct?
Yes, I'm at the, our address is 2230 Northwest 95th Street, right up the street from Central.
Right.
Like off of 22nd Avenue, that's where I'm at. But we have locations, you know, various facilities, but our facility is relatively new. We've been open now for 6 months, and we're definitely growing and happy to accept new patients.
Okay, great. I did have a question before this question. I don't remember what it was now, but
you said the patient was diabetic?
Yes, the patient is diabetic. Yeah.
We have
we take care of everyone.
Take care of them as well.
We have podiatrists, on site.
Well, I think definitely. Oh yeah, okay. But I think definitely, Dr. Joseph, you're definitely going to be getting the call. Absolutely. But listen, audience, 305-825-2977. 827-2977. Okay, this is in the Miami area. Okay, this is, well, I think you said you have in other centers across, but anyway, this is for Miami, of course, and just in case those who may be in Broward or Palm Beach or what have you that are watching. So we just want to make that point. But listen, we're going to get off of here. Thank you again, Dr. Joseph. Thank you again, Ms. Rowe, for your participation in this very important conversation as far as raising awareness to prostate cancer. I think I can tell you the truth. I've learned a lot just by hearing it, along with the other research that I have been doing for myself. Because to tell you the truth, I never really thought about it to the magnitude, but I can tell you right now that I'm a lot ahead of the game now, especially because of my age and me being an American who happens to be Black. I'm on it now. I am on it. So, but again, thank you so much, and we certainly appreciate you. And I want to say thank you to all of our guests, not only our guests, but our viewers, and for watching and your participation. Listen, share this video, contact your family members, husbands, fathers, uncles, whoever, your sons, and let them know, hey, don't take your life or your health for granted, okay? Invest in it. It is worth the investing, all right? But anyway, without anything else to be said, thank you all, and y'all be blessed.
Have a good night, everyone.
Lionel Nelson here, and welcome to A Father's Note, promoting fathers through building men. We want you to know we're with you. We're standing behind you 110%.